Hi, welcome to another fantastic episode of You Didn't Get the Memo. I'm your host, Gloria Bailey Ray, and as always, we have a fantastic show. I am telling you today, I am so thrilled and excited about my guest that we're going to have on. It's going to be talking to you. We're going to be dealing with some breast cancer and cancer stuff. All right, y'all. So don't go anywhere. But let me just tell you, for those of you who are new and you've not tuned in to You Didn't Get the Memo show, this is a very interactive show. If you have questions or comments, you can place them in the comment section and we'll do our very best to respond to them. You Didn't Get the Memo show is about providing you, the viewer, with relevant, fact based information to help you be informed and to make informed decisions. We are international and we're national. So I'm giving a shout out to all of you and thank you guys so much for tuning in. My guest today is Dr. Cheryl Ewing, clinical professor of surgery at the University of California, San Francisco, better known for those of us here, UCSF. As you know, UCSF, or may not know, is a prestigious academic medical center that's known for innovation in medical research, public service, and patient care. But in addition to that, the medical center's nationally preeminent programs include cancer, children's health, neurological diseases and disorders, organ transplantation, and women's health. I'm excited to welcome to the show today, y'all, Dr. Cheryl Ewing. Dr. Ewing, thank you so much for joining us today.
Gloria, thank you so much for inviting me to be part of this forum. I
Oh,
hope that I can send out a lot of useful information to your listeners.
look, I am confident that you will, and I'm ready to get into it. You heard me talk just a little bit. It was more about, where you are at as a clinical professor of surgery, but I'm going to start it off by asking you to give our viewers a little bit about your backstory, who you are and why and how did you get into this particular field?
Well, as I've told many young people, that my family was not rich growing up. We didn't have any special connections or, any special favors. But my mom did teach me how to read when I was 3 years old and taught me to love books and just to learn. And from the time that I was 5 years old, I wanted to be a doctor. I didn't know what type of doctor because I didn't know anything about medicine. And none of my family had ever gone to college. But I knew I wanted to be a doctor. So my whole lifetime growing up was just focused towards just learning and reading and preparing to go to college.
Well, I think the nice thing about that, Dr. Ewan, is simply this. It's an encouragement. This is what the show is about. It's to encourage people that irregardless of your situation, that you can do and be. And hearing you say at 5 years old, you may not know exactly what kind of doctor you're going to be, but I'm going to be a doctor. And it's living that dream. And I am excited to have you on and to talk about this particular area because as we all know that when we talk about cancer and just even hearing those words, what does it do? It just causes people to shudder. They shake and quake in their shoes. So I want to just start with just asking you, in your opinion, and when you're explaining to a patient, what is cancer and how does cancer develop? And I know that that's broad, but at the same time, if we can kind of do that Reader's Digest version, if I walked into your office and I would be, Dr. Ewan, what do you mean? What is cancer?
Mhm. So, as you know, throughout your life, um, all the cells in your body are replaced in a regular manner. For example, if you get a cut on your skin, skin cells will divide and heal that incision, where your entire body goes through that process of renewing your organs, your skin, your hair, and that's how hair grows. But what happens with cancer is the growth becomes uncontrollable and completely unregulated and just takes over the body. So, for example, if you have a cancer that develops in the breast, it can take completely over the breast of these uncontrollable growth cells. And then it can spread to other parts of your body and take over that, your brain, your lungs, your liver, your bones. And so you can see eventually the body will succumb because it's taken over completely by these cells who have no function to provide. Uh, it doesn't beat your heart. It doesn't process food in your gastrointestinal tract. It doesn't do anything other than take over your vital organs.
And as we know, and I know for me personally, cancer has affected so many family members.
Yes.
And that's why I felt that it's important. I know people, we have breast cancer month and we have all these other things, but to me, talking about it and educating people about it, there is always the right time. I don't have to need to wait for a month for it to come around. So when we talk about cancer, tell us about what are some of the more common types of cancer, and in particular, what I found was interesting how these cancers are named. For instance, carcinoma, sarcoma, leukemia. But what are the more common types that maybe you see in your practice?
Well, the cancers are usually named for the organ that they arise in. So you can have lung cancer, and that's a cancer that arises in the lung. So it's called a lung cancer.
Mhm.
You can have a breast cancer, which there are two types, and I'll swing back to that. Or if you have a cancer that forms in your soft tissue, for example, in your muscle, that's called a sarcoma. So the name of the cancer is based on the origin of the cancer. What organ did it originate from? And hence the name. Now, for breast cancer, the breast is composed of two components. There are the glands that make milk, and there's the ducts that carry the milk from the glands to the nipple for breastfeeding. Pretty straightforward of the female breast. And cancer cells will either arise in the milk glands, and we call those lobular cancers, or they will form in the ducts, and we call those ductal cancers. And so those make up probably about 90% of all breast cancers.
So, and you actually answered the question I was going to ask, like what is considered the most common form of breast cancer that you actually see. So, ladies, I hope that you're listening. Gentlemen, also pay attention. We need to know this information. So, when we talk about biomarkers, what are biomarkers and what is the importance of, these biomarkers?
Right. So the biomarkers give us the characteristics of that cancer. How aggressive is it? How should we treat it? What should we treat it with? And so the biomarkers are markers that on each cancer, each patient's cancer will have a, their own personal biomarkers. And what it is how sensitive is the cancer to estrogen? How sensitive is the cancer to progesterone, which are female hormones that stimulate growth? Uh, is it another biomarker that we look at is called the HER2, which is a growth receptor that will tell us how aggressive the cancer is. Another biomarker that we look at is called the Ki67, which tells us how rapidly those cancer cells are dividing. So remember, part of the cancer problem is the cancer cells are dividing and taking over the body. So we need to know how rapidly that's happening. And then based on that information, we can decide what type of treatment will best address that. But one of the things that has really has become so impressive and have kept me in the game for over 30 years, we have such effective treatment that we identify the cancer, we individualize the cancer, and then we give each patient a specific therapy for their individual cancer. And it may not be chemotherapy. We have these new targeted agents that you see advertised on TV all the time that have very few side effects. But we find the biomarkers. It can also be the DNA profile of the particular tumor. And so with all that information, we can give specific medications that's specific for that cancer cell that will block its growth. And so it's made a huge improvement in patients surviving breast cancers. Even when they come to us with late stage or locally advanced breast cancers, they do very, very well with these new therapies.
Wow, that is awesome to hear. Dr. Ewing, we're going to take a quick break. And when we come back, let's delve more into talking about breast cancer signs and symptoms. What should people be looking for and
Sure.
observing? Because of course, as we know, it's really interesting. We live with these bodies, but it's so amazing how people don't pay attention to things that crop up or come up, and it's a little abnormal. But guess what? People still don't pay attention. So when we come back, let's talk about that. You guys don't go anywhere. Thank you so much for tuning in. And we will be back with my awesome guest, Dr. Cheryl Ewing.
Let's get back to talking smack with a side of mac and cheese.
Before we can safely come together, we need the facts on COVID-19 vaccines.
To get the facts, visit getvaccineanswers.org so you can make an informed decision when vaccines are available to you.
All right. Thank you guys so much for hanging in here with us. I have with me today on the You Didn't Get the Memo show, Dr. Cheryl Ewing, who is the clinical professor of surgery at the University of California, San Francisco, UCSF. I have to think about that. University of California, San Francisco. And before we went to break, one of the questions that I posed to Dr. Ewing was to talk about some breast cancer signs and symptoms, things that people tend to overlook. What should they be looking at or observing? And I'm going to start with, I think one of the first thing is for women, just examining the breast, right? And it's something that you kind of talk about or hear your PCP maybe say to you when you go there, if you do an OBGYN checkup. But let's just really delve into that and talk about that. So signs, symptoms, Dr. Ewing.
Okay. So I always trust that no one is going to know a woman's breast better than the woman. So doing monthly breast self-examination so you can be familiar with your breast is very helpful in spite of some of the recent data that has been somewhat controversial about that. But doing a breast self-examination is free. And so I recommend that you pick one day a month, your birthday, your husband's birthday, your partner's birthday, your dog's birthday, just some birthday that's special to you. And pick that day. It's going to be your day that you do a breast self-examination. And the best time to do a breast self-examination is in the shower when you're soapy, because it makes it easy to glide over the skin. And if you feel a lump in your breast that you said, that wasn't there before, and if it persists for more than a month, then you should probably have it evaluated. Most likely it will not be cancer, but it still is prudent to go ahead and get a persistent mass that's, from 1 month to the next, to go ahead and get that evaluated. Some of the other things that you're looking for are just changes on the skin or your nipple. If you notice that your skin is getting pulled in or what we call retracted in a certain spot, that's something that needs further evaluation. Or if you notice that one breast is becoming smaller than the other or becoming larger than the other, changes in size is something that needs to be evaluated. And then lastly, if you notice that you're having nipple discharge, particularly if it's bloody, you should probably have that evaluated. So those are some of the signs and symptoms that we're looking for. Or an open sore on your breast that just will not heal, and it's not an insect bite or it's not trauma, but it's just persistent and will not heal. That again is something that needs to be evaluated. So skin changes in the size of your breast, skin retraction, nipple discharge, or a lump in your breast that you felt, I have not felt that before.
And you talked about the fact that there could, breast changes. I have to say at times, as I've gotten older, I want to know whose breasts are these because they aren't mine, right?
But they do tend to go south as we get older.
Yeah, but the reality of it is when you're doing a mammogram, which at some point I'm hoping that they will be able to make that machine so it is not as painful. But how reliable? I know the mammograms do catch some things, but I recently had a friend of mine who had a mammogram, and they saw something but wasn't for sure, and she was in a panic about it. But at the same time, of course, it turned out to be nothing, just, just the changes in the, mass in her breast. So when people are having mammograms, what do you say to them if they come to you and say, look, my mammogram showed this? Because sometimes some doctors are actually more proactive to
Mhm.
refer patients as opposed to not. So
Right,
with regards to mammograms,
right,
should women be getting them? And I've understood that there's a certain age where they just stop altogether. So can you
right,
speak to that?
right. So that's actually one of the trials that we have going on. Is called our mission trial. And so what we're trying to determine is who what women should get mammograms every year, what women should get mammograms every 2 years, what women should get mammograms every 5 years, and when should we stop? And it's just based on their level of risk for breast cancer, either based on their family history or they carry a genetic mutation that puts them at risk for breast cancer. So, but until we have those questions answered through our trial, we're recommending at least starting at age 40, getting a mammogram every year or every 2 years based on your family history. Now, mammograms are pretty good at picking up early breast cancers. It's about 85% specific for picking up breast cancers. And even if you do have an abnormality on your, because I know a lot of women get stressed, they get a mammogram and then they get called back for further studies. More often than not, when you come back for that second study to confirm that there's an abnormality or not an abnormality, most likely it's going to be totally benign, um, at least 75% of the time. So, I don't want women to panic because you get called back for what we call a second visit, that you have cancer. Statistically, most likely you will not have cancer.
Mhm.
But it's important to follow up because that's when we catch the early stage breast cancers.
Right, right. So what I hear you saying is instead of you panicking and not do anything,
Right,
have follow up
right,
because some people like I can't go through this. I can't go through this. And I hear that and I'm thinking you want to know. You
right.
because
And
that way it
and
allows
here's
you to
the
have a plan.
right. A lot of women think that having breast cancer is an automatic death sentence,
Yes,
when
yes.
it's completely the reverse. Most women by far do very, very well, even when those women present with an advanced breast cancer, even with metastatic disease, they they survive. So I don't want women to panic that they may have breast cancer when most likely they do not. But even if they do, overall they're going to do very well.
Yeah. Okay.
But they
Well,
just have to get in to see people like me.
right. Okay, we're going to get into that because that leads into some healthcare stuff, right? For sure. But let me just ask you this. When we talk about breast cancer, tell us briefly about the stages of breast cancer because there are different stages. So
Right.
talk about that, please.
So we don't use staging so much anymore as we learn more and more how breast cancers impact on someone's life, whether or not it will metastasize, whether or not it will grow uncontrollably. It's more based on those biomarkers that we just talked about that will set how aggressive we should be. But the old staging system, the one that most the public hears about, is based on the size of the breast cancer, is based on whether or not you have lymph nodes that are involved with cancer, lymph nodes under your arm on the same side as your breast cancer, and whether or not that cancer has spread to your vital organs, to your brain, to your lungs, to your liver, to your bones. So that doesn't accurately tell us, or is not very predictive, how a cancer will act at diagnosis based on the stage. But the biomarkers will tell us how aggressive a cancer will be and how likely it is for those unfortunate outcomes to happen. So we go more on the biomarkers than the staging to help us decide how aggressive we should be with treatment.
Okay, that's good to know because I came up, of course, with talking about staging. What are the stages? And so that's good to know. Which leads me to ask you this question: can males develop breast cancer?
Yes, they can. About 4% of the male population will
Hmm,
develop breast cancer. And most oftentimes, when you see a breast cancer in a male, it's associated with a genetic mutation. So, if any of your listeners or viewers have a male relative with breast cancer, they should absolutely get tested to make sure that they don't carry the breast cancer gene.
oh, awesome. Okay, 4%. That's still Oh, all right. So let's talk about risk factors. Risk factors are contributing factors in relationship to women getting breast cancer. And what I mean, does age or race or family history? I know probably some of that, and we touched on a little bit about the breast density, but
Mhm.
what about exposure, to DES or sun or radiation, smoking? And I threw
Right.
out all these things, but let's talk about the risk factors because I think that that's really important. You hear that, and I know it's been beat in our heads for years, especially things around, family history, around smoking. But, that's why we're here. Let's have that dialogue. So when we talk about risk factors, in your opinion, what is it that you would see and would say, yeah, these are more of what I see as risk factors as opposed
Right.
to some of these.
Right. So first, we divide risk factors on two track lines. One is genetic, and the other is environmental exposure. So let's first talk about genetics,
Okay.
because that's the more dominant one. So that's based on your family history. I can't tell you how many women I have who come to see me who've got a significant family history for breast cancer or ovarian cancer or melanoma, and all of those cancers are tied to breast cancer. So if you have that family history and you only need one or two relatives, and we define it as first degree and second degree, and if you have any relative diagnosed with ovarian cancer, even going far back as a grandparent, that might put you at risk of getting breast cancer, and you should undergo genetic testing to make sure that you don't have the breast cancer gene. So that's one group with risk. It's just based on their family history. And remember, you only need to have one or two first degree relatives diagnosed with breast cancer to fall in that category. And that's first degree relatives are mother, sister, daughter with breast cancer. Age is the second factor. So between the ages of 50 and 65 is when the risk is highest based on age. So that's the second group. And then the environmental factors are early exposure to radiation. I don't know how many of your viewers are were teenagers in the 50s and 60s, but do you remember when they used to use radiation to measure people? You do X-rays to measure people's shoe size,
Yes.
or use radiation for acne treatment,
Mm-hmm.
and also meant what we call radiation to the chest for certain lymphomas, cancer of the lymph nodes. So radiation exposure under the age of 20 puts someone at significant risk for breast cancer, and they
Mm.
should absolutely participate in a high-risk clinic to be screened. The other risk factor is if you grow up in a farming community, it's felt that pesticides may play a role in, in a risk for breast cancer.
Mhm.
And then lastly, alcohol has been deemed as a risk factor for breast cancer, but it's not the alcohol itself, it's the weight gain associated with
Really?
risk, because alcohol has so many calories in it, and the peripheral body fat makes estrogen. So if for women who are somewhat overweight, their baseline estrogen level is higher than a thinner woman. And so that's a lot of estrogen stimulation to stimulate cancer cells. Just like taking estrogen replacement after you go through menopause is
Mhm.
also a risk marker for breast cancer. So those are some of the environmental factors.
Okay. Look, I'm sitting here going through my head. I'm like, all right, Dr. Ewing.
So the best thing is just to maintain a stable weight. You don't have to go on some crash weight loss program, but just
Mhm.
try and maintain your weight.
Right. Okay. All right. So, what about women who have never had children, right?
Right,
Are they at greater risk? Now, I know that you talked about the genetic piece, right? With the, mom, sister, but what about women who've never had children?
right,
Are they at greater risk? And these women have been on birth control for like years. So
right,
can you speak to that? Because
right,
now all of a sudden now you can get birth control in the mail. You just say, I want
right,
birth
right.
control, and you order this delivered to your door. So I mean,
Okay,
how
so
does that work?
okay, so interestingly enough, birth control pills and fertility injections, for childbearing, doesn't seem to have a role in increasing your risk for breast cancer.
Okay.
But not having children or having very few children over the age of 24. So You have to be under the age of 24 to decrease your risk. But the risk is not that high. We're talking about a 1 to 2% difference. So we don't consider it significantly enough risk factor to counsel women about having children as it relates to breast cancer.
Okay. Okay.
The risk differential is just not that different.
Oh, okay. All right. So for all you single ladies out there that would rather have your cats and dogs and what have you, you just heard it. All right. The thing is not to worry, because I know a lot of women. I have some
I mean,
friends.
there is a slight elevated risk, but again, we don't consider it to be significantly
Yeah. But
different.
for women to worry so much about, oh, I wish I had kids when I was in my 20s, and
Right.
now I'm 50 and I don't have kids, and I mean, for some women, that's very
Right.
significant for
And
them.
interestingly enough, breastfeeding does decrease the risk of breastfeeding, but of breast cancer, but you have to breastfeed for at least 9 months to
Hmm.
impact on that risk.
9 months.
9 months.
Look, I'm gonna
That's
leave
a
that
long
right there.
that's a long time with that's a long time with those little teeth.
Look, okay, I'm like, okay, I gotta leave that one right there. But you know what? We're gonna take another quick break, and when we come back, let's talk a little bit. I want to delve into barriers that are affecting diagnosis for
Right.
women of color, especially, and
Right.
being treated. So you guys don't go anywhere. We'll be right back. Thank you guys so much for tuning in, hanging in here with us.
You know, a lot of people say when you're going somewhere, you don't look back. But I beg to differ. I can't lie and say it was easy. I looked at everything in a different light. I realized it started with me going back and getting my high school diploma.
My uncle, Freddie Lee Tyson, was a part of the syphilis study. He was such a wonderful man, a very loving, very caring, very jovial person. He helped build the air base at Moulton Field. When you think about the Tuskegee Airmen, all of the greatness that they did, and then in this same space, such an atrocious study was being heaped upon our men, that really shook my spirit. They were not being treated. That is very different from what's happening with COVID-19. The vaccine is being made available to anyone who wants it, even those who find themselves at the space of hesitancy. We have to have patience and give them the requisite information that they need, that they can make an informed decision. But let's do it out of love.
All right. I want to thank you guys so much for hanging in here with my awesome guest, Dr. Cheryl Ewing, who is a clinical professor of surgery at UCSF. And we are just delving in and talking about, I call it, let's have the cancer talk. Let's talk about it, right? Before we went to break, I'm really excited to get your input on this, Dr. Ewing, is the question, first of all, if I were going to say the top bulleted point is cancer disparities, right? But what are some of the barriers, in your opinion, to women of color getting, first of all, diagnosed and
Right.
getting treated?
Right. Right. So one of the things that we as people of color have to advocate for ourselves, uh, because sometimes our complaints are ignored or not taken seriously or not followed up. So that's the first rule, that we have to advocate for ourselves because no one else is going to advocate for us. So some of the other barriers are just access. So if you have minimal health insurance or no health insurance, and you have a decision about whether or not you're going to pay your rent or get a mammogram, guess what's going to win? So access is a huge problem that in some ways are being addressed with the Affordable Health Care Act. And also some programs that we have in California that's unique to California. It's unfortunate for some of the women in other regions of our country that have no access. But the majority of African American women still live in the South, where there are some of the healthcare systems there are just atrocious. That Medicaid was not allowed to be expanded, so some of them cannot participate in the subsidized affordable healthcare system. So access is another, and then thirdly, just fear of the healthcare system. because of our past history of dealing with the healthcare system and all the injustices that were done to us in the past. So those are the three main barriers that we just have to work around. But advocacy for yourself is number one.
Mhm. Yeah. And would it be, well, for me, I find that it is appropriate to you talk about advocating, and that means at times pushing your physician to do more than just just say you got this and kind of like that's all it is to it, because that's not it. And even when I personally have found growing up in the South that a lot of times, people of color are hesitant to, it's that respect thing. I don't want to disrespect you,
Right,
but and I want people watching the show to know it's not about disrespect. It's about you living or dying.
right, exactly.
That's the reality. And sometimes it's I liken it to this. Would you rather have a doctor who is really, really good and has atrocious bedside manners, or do you want somebody who's going to pat you on the hand and just send you on your way? I
Right,
want the guy who has atrocious bedside manners, but I know he's going to take care of what needs to be taken care of. And
right,
we have to kind of look at it like this. Are you going to be that person who's going to be, just forthright and say, no, I'm not accepting this or not? And that's around the country. I mean, y'all, I mean, this is 2022.
hmm,
And for people to not feel like that, and maybe you may see it there at UCSF, but I do know that when you push the envelope, they say, well, wait a minute, there's something about this person that's different from maybe the other patient, and we need to look at that. And I want people to know and to hear just what you said. Yeah, you may have access, but then what else is out there? And nowadays, with the internet, there are things that you can find and
hmm,
areas and places that you can go. It may mean you have to drive 2 hours if you're
right,
in someplace like Mississippi or Alabama,
right,
but if you're going to get what you need, I would think that you would agree that they need to push that envelope and they need to go there and get seen and get taken care of rather than just accepting it. And that's what I see so many times that
right.
people tend to just give up. It's a death sentence. I got breast cancer. It is what it is. I'm gonna live the best life I can. And it's like, who does that?
Right.
Right?
So that's why I said my number one thing for access is self advocacy, and not just to advocate for yourself, but also for your family and friends.
Hmm.
Because you may have a family member that's just incapable of advocating for themselves, and you just may have to step in to assist to see that specialist. Or if you're talking to a physician about whatever is going on with you and you don't understand, don't leave. You need an explanation. They are obligated by our Hippocratic oath to give you all the information that you need to understand the process.
Yeah. And you just touched on something. They're obligated. And one of the things that you hear is physicians are stretched so thin, and literally they have less than 5 minutes, supposedly, to come in to see a patient, make a diagnosis, have a treatment plan, write a prescription, and out the door. But that one thing, I made an appointment to see you. At least that's my attitude. And by the way, y'all, when you're going to see the doctor, you need to have a list written down. What are your complaints?
Right.
That actually helps him or her.
Yes.
Why are you here? What are
Yes.
your complaints?
Right.
How
What
long
are your questions?
Yeah, and to come in with that, and for them to answer that, and if they don't, there are other avenues that
Right.
you can take. But I think that that's the first part of feeling like you to empower you to
Right.
say to the doctor, you haven't answered my questions, and I need to know
Right.
what it is. What
Right.
does this mean? And I laugh sometimes. I say to my husband, I know this doctor. He's like sick of me emailing. Look, I haven't gotten the answers that I need. And so therefore I need, and of course now with them being able to FaceTime or Zoom or whatever they call it,
Right.
you can see your doctor, you guys.
Right. I Zoom all the time with patients.
Yeah. Okay. So see,
Right. So one of the things that we have at UCSF at our program is that we have a collaborative planner for
hmm
our patients. And so what they will do is one of our assistants will call the patient the night before their visit
hmm
and just kind of go over their questions and what their concerns are and document all that. And then they provide that information with me. And then that planner will actually sit in on the visit and transcript it for the patient.
Awesome. Now that's awesome. That helps. I think that that's really key. Good customer service is what I call it. Because we need it for sure. But
Yeah,
with
but you know, we're UCSF, we try harder.
right, right. Well, I can say that I personally have had experience with some of family members in the transplant unit, and today he's 24, 25 years of age, and that started when he was, I don't even know, not even a year. So, I know what UCSF can do, and I mean, I'm a firm believer in that. At the same time, let me just ask you this. When we're talking about advocating for your health, but you know what? There's still that challenge with the level of care for women of color who fail to get the same as compared to their white
Right.
affluent counterparts. And that piece I still grapple with, I still deal with. You walk in and because you made a huge donation, or people know that you are affluent.
Right.
And perfect example of this, Dr. Ewing, back in the day when I was doing pharmaceutical sales, we would have samples. And one of the things that I noticed in some of the physicians' office is the people who could pay for the prescription got the samples. And the patients who didn't have good insurance or no insurance, they weren't given the samples. And that right there, just goes to show,
The disparity.
Absolutely. So even with an institution like UCSF or any of the majors, I don't care if you're Emory or, in UCLA, one of the things that I really am hoping is that these institutions are hoping to close that disparate gap as relates to, BIPOC people or just poor people.
Right.
They need the drugs, but they can't get it.
Right.
So any suggestions on besides just advocating for yourself? Because
Right.
people feel they get tongue tied when they're talking to doctors.
So there's a lot of things that people can do. There's these new generic services that you can ask for if you need a prescription for a drug that's particularly expensive. There's these new generic services that will usually provide the drug at an extremely discounted price. Sometimes they're 95% difference in the cost. So that's one thing that you can ask for your doctor who's prescribing. The other thing too, if you are going through a newly diagnosed breast cancer, seek a second opinion with a specialist, particularly if you're getting treatment out in the community. You want to check the credentials of that person. Are they specially trained to take care of patients with cancer, or are they just a generalist that's caring for you? So seeking specialty care. And even if you're a Kaiser patient, you have to be treated at Kaiser. There's no getting around that.
Right.
But you can get a second opinion from Kaiser. Outside the Kaiser institution. You can go to other institutions for second opinions.
Oh, okay. See, that's really good to know. So basically, you guys, you hear, you don't have to just accept it as they say, as the gospel, what you have just been given. And I love that. I think that that's a great information. But let me just go back to a couple of things as relates to the disparate health care. Mortality.
Yes.
I think that it's still at a much higher level than it should be in this day and age of what we're living with new drugs and new treatments. So can you speak a little bit too about the mortality rates, and especially I'm speaking of in relationship to people of color?
Right. So our mortality rate for African American women's death is about 10 times higher than their white counterparts. And the two reasons is, again, health disparity. But another reason is that African American women are diagnosed with breast cancer at an earlier age than their white counterparts. And so you're not looking for breast cancer at age 24, 25, 26, but it happens more often in African American women. The other thing, we talked about biomarkers to tell you how aggressive the cancer are. We also tend to have the more aggressive biomarkers. So not only are we diagnosed younger, we also tend to have a much more aggressive form of breast cancer. And then when you put that on top of health disparity, where you're not getting screened or getting appropriate attention to your problem, it impacts on the mortality rate. So
Wow.
that's one of the things that we're actually trying to work on, to get the word out that young women should be, at least have a physical examination at least once a year by their gynecologist or their family practitioner.
Oh, wow. You're saying that's early 20s.
So 25 and above.
Yeah.
Usually when we recommend to start.
Oh, okay. All right.
So
Wow.
it's just part of your usual health maintenance.
Okay. All right. So you guys heard it. This is really, really key. So let's talk about survivorship.
Mm-hmm.
Still staying in that realm of healthcare disparities.
Right.
So, you just said that I'm reeling from the mortality rates that you said. So when we talk about survivorship, what do those numbers look like?
So the survivorship, it has made a huge difference in the last 15 or 20 years.
Mm-hmm.
We're increasingly becoming on par. When you get someone in treatment, we're increasingly, that gap between Black women and white women is narrowing dramatically, particularly again in the last 10 or 15 years, as people just become more informed and have better access to healthcare.
Mm-hmm.
But some of the post-survivorship that women in our community may not get, sort of what we call survivorship support,
Mm-hmm.
about how to manage hair loss or memory loss,
Yeah.
or vaginal dryness that you might get with some of the therapies, how to resolve those issues, how to, the trauma of undergoing breast cancer treatment, do you have the appropriate support systems to help? For example, we have in-house therapists to help our patients, because it's a huge deal to go through this process.
Yeah.
And it's a huge impact on women, particularly when they have young children. So do they have assistance to help with their, with their children, with their families, with, just support? And so some in our community just don't have the same support as some other communities.
Right.
So those are the things that we're trying to focus on.
Okay. As it relates to survivorship,
That is survivorship.
right there.
Is your quality of life after breast cancer treatment. When you're all done with treatment and now you're kind of, in a routine
Mm-hmm.
life, how's your quality of life after all of that?
Mm-hmm.
And sometimes women need more support.
Right.
Just because you're done with your treatment does not mean you're done.
Right, right. And then the thing is, if I can say, for Black women, I used to laugh at that commercial, the woman's I can bring on the bacon fried up in the pan and all of that. But, the reality for women of color, and especially Black women, when you're a single parent household, you've got 2 or 3 kids or 4,
Right.
and you're trying to work, you're trying to take care of the kids, you're trying to manage your day-to-day bills, activities, and then you toss in all of these other things on top of that.
Right.
That's a lot.
Right.
That's a
So
lot.
you just have to be aware of trying to provide support systems for those women in your community and in your family, because they do need a little extra attention, even when they're done with treatment.
Mm-hmm. That's good. That's good. Dr. Ewing, when we come back, one of the things that I'm just going to ask you about, to talk just a little bit about the treatment plan and follow up with your patients once they're diagnosed. And the last question will be, what do you want viewers who are watching the show to take away? So don't go anywhere, you guys. Thank you so much for hanging in here. I really appreciate it. You're watching the You Didn't Get the Memo show with Dr. Cheryl Ewing, clinical professor of surgery at the University of California, San Francisco. We'll be right back, you guys.
Thank you for watching the You Didn't Get the Memo show with your inspirational host, Gloria Bailey Ray. It's your contributions that make this happen. To become a sponsor, send an email to youdidn'tgetthememo@gmail. That's the letter U, didn't get the memo. If you're not in a space to be a sponsor, but you like what you hear, we simply ask that you support what you like by making a contribution to the show. There are 3 ways to make an online donation. Visit paypal.me/Gloria Bailey Ray or Cash App or Venmo. Gloria Bailey Ray. Give what you can. Your support is appreciated.
All right, you guys, thank you so much as we wind down this awesome discussion with my guest, who I always like to say to young people, say she's dope. She, Dr. Cheryl Ewing. Before we took that quick break, one of the things I just asked Dr. Ewing if she would share with us, just kind of talk about what a treatment plan or a follow-up plan with patients who've been diagnosed with cancer. You've given us a lot of stuff, but right now I'm just saying, can we just kind of encapsulate it all and like bullet point 1, 2, 3, 4, what would that look like?
So for most women who are entering, they're diagnosed and now they need to undergo treatment, usually the first person that they'll meet in their care team is a surgeon. So you can think about the surgeon as a conductor for the other members of your care team, which would be a medical oncologist who delivers medical therapy and a radiation oncologist if radiation is indicated. So that's the usual care team for most patients undergoing treatment, that you'll have 3 different physicians, all oncologists, but looking at cancer treatment from different disciplines. For example, I'm a surgeon, so my discussion with patients is around surgery. A medical oncologist is the person who delivers medical therapy. So they're giving you either chemotherapy or an anti-estrogen pill that we call hormonal therapy. And then if it's indicated that you need radiation, it would be the radiation oncologist that would deliver the radiation. So all oncologists, but looking at it from different disciplines. But the first person almost always that you will meet is a surgeon. And so the surgeon is kind of the conductor that directs the patient which track they need to go on. Do you do surgical therapy first? Do you do medical therapy first? Or do you do radiation first? And then if it's surgery, it's my job to, based again on their presentation, those biomarkers that we just talked about, and some other factors, to counsel the patient what is my recommendation for surgery and the timing of that surgery. So that's usually how the treatment plan will go. It's a decision tree based on each individual patient. So there is no, global treatment plan that we come out with for everybody. It's very individualized based on those patient circumstances and the presentation at diagnosis.
Okay. All right. So, Dr. Ewing, for the people who are watching the show, what is it that you want them to take away from the show today, what we've discussed?
Okay. I one of the things I want them to take away is that having a breast cancer diagnosis is not a death sentence. We have such effective therapies. It's just unbelievable how well women do. So that's the first thing, just to take the fear out of it. Advocate for yourself. If you have a concern and you feel like your issues are not being addressed, just go ahead and advocate for them, and get proper screening. To get a mammogram once a year or every 2 years can save your life, particularly if you are at increased risk for breast cancer based on your family history or you carry a genetic mutation.
Right. Well, you guys, you've heard it. And Dr. Ewing, by the way, I know how busy you are. So I need to say I'm not only humbled and honored that you would take the time out of your day to give us this information and to talk to the viewers. So I want you to know how much I thank you for being here on the show. Don't go anywhere. I will be right back with you. I want to say to all of you, again, I want to thank my guest, Dr. Cheryl Ewing, for being on the show today. Also, just a gentle reminder to remember to support our efforts by inquiring about our sponsorship package or opportunities. It's never too late to do that. And if you're not in a space to become a sponsor, you can still support by making a donation of any amount. There is a blessing in the giving. I want you to be sure and follow me on all my social media platforms and mark your calendars for every Tuesday, you guys, 5 p.m. Pacific Standard Time for the You Didn't Get the Memo show. We always got something great and exciting for you. I appreciate all of you. I want to thank you for your support, for tuning in. Be sure, again, to share, follow, like on Facebook, YouTube, and I'm also on LinkedIn and Instagram. It's been a blessing, as I always say. If you didn't take anything away from today's show, then it's you who didn't get the memo. So remember this, the quality of your life is determined by the decisions that you make. I'm your host, Gloria Bailey Ray. Until next week, be well, stay blessed.